superficial fungal infections of skin. Most mycotic infections are superficial and are limited to the stratum corneum, hair or nails. Deep mycosis are evidence of disseminated infection, typically with a primary pulmonary focus. Few deep mycosis like sporotrichosis, pheohyphomycosis and chromomycosis result from direct inoculation into the skin. I will be speaking to you on the pathophysiology, clinical types of infection, laboratory diagnosis and treatment of dermatophyte infections, tinea versicolor and candidiasis. The superficial dermatophyte infections are classified for ease of management and diagnosis depending on the site on which they occur into tinea capitis, tinea barbae, tinea fishiae, tinea copperis, tinea pedis, tinea cruris and onychomycosis. Moving on to the pathophysiology of dermatophyte infections. Dermatophytes, which include Microsporum, Epidermophyton and Trichophyton, live in the superficial layers of the skin, hair and nails. The presence of serum inhibitory factors prevents them from invading living tissue. The clinical manifestations depend on the infecting species, the site affected and the immune status of the individual. Susceptibility to infection occurs if one is on oral steroids, in immunosuppressed states like primary immunodeficiency syndromes and cancer chemotherapy, if one has a defective cutaneous barrier caused by widespread disease like ichthyosis, in a tropical climate, or if one is in contact with infected animals. Moving on to tinea capitis. This is caused by all dermatophytes except Epidermophyton flucosum. It is usually seen in children. The common clinical types of tinea capitis are the black dot variety, Kyrian and Phoebus. The black dot variety is the most common type of tinea capitis seen. What one sees is broken off stumps of hair, often in rounded patches with crusts or pustules. These broken off hairs are loose and when examined are found to be surrounded by or contain fungi. Kyrian produces tender, boggy plaques exuding pus. This may be followed by scarring and permanent alopecia. Phoebus, yet another type of tinea capitis, which is extremely rare in India, presents as concave sulfur yellow crust surrounding the loose, wiry hairs. Sometimes tinea capitis can present with diffuse scaling mimicking seborrheic dermatitis, or the common name for that being dandruff. And this is usually caused by Trichophyton tonsurans. This is a picture of Kyrian. Here you can see the boggy swelling and the crust and the broke and absence of hair. The diagnosis of tinea capitis is usually by KOH examination of the hair and by using a wood slide, which is a special lamp by which you can see the fluorescent positive infections. And these fluorescent positive infections are Microsporum canis, Microsporum ordinae, Microsporum ferruginum, and Trichophyton schonlani. The treatment of tinea capitis is by systemic therapy, which includes griseofulvin, terbinafine, or itraconazole. We can also use selenium sulfide or ketoconazole shampoo, which is left on the scalp for 5 minutes, and this is done 3 times a week, and this is an adjunctive therapy. I will come to a more detailed description of the treatment a little while later. Tinea corporis refers to infection of the glabrous skin. This form of tinea is characterized by one or more itchy, circular, sharply circumscribed, slightly red or erythematous, dry, scaly patches. The advancing edge is usually prominent and a central clearing is evident. Now this is a typical picture of tinea corporis showing all the features I described in the earlier slide. Here again is tinea corporis. Here you can see the scaly margins. Now in this case the tinea corporis is eczematized, which happens when we have an infection with zoophilic fungi. The lesion tends to be very inflammatory then. Now this is a KOH preparation of a scraping taken from the skin, and here you can see the thin septate branching hyphae of dermatophyte infection. And this is just a very magnified view of the dermatophyte. Now the treatment of tinea corporis. Localized disease is treated with topical antifungals, usually meconazole or clotrimazole for about 4 weeks, and extensive disease is treated by any one of the systemic antifungal agents. Tinea pedis occurs in 3 distinct patterns, which in turn depends on the causative organism. So the 3 patterns are vesicular. This usually affects the insteps and sides of feet and tends to be unilateral. Intertriginous dermatitis, on the other hand, presents as peeling, maceration and fissuring affecting the lateral toe clefts. Then you have the squamous hyperkeratotic type, which affects the soles, heels and sides of feet. And what one must remember is that there may be an associated infection of the nails. Tinea manum refers to infection of the palmar skin. This presents as hyperkeratosis of the palmar skin with accentuation of the flexural creases, which is very characteristic of this condition. It can also present as circumscribed vesicular patches. And this is a picture of tinea manum. What you can appreciate here is just the erythema of the palms. The fine scaling, which is not very evident on this slide. Tinea unguum is characterized by fungal infection of the nail. Now this is seen in approximately 40% of patients with fungal infections in other areas. The types of tinea unguum. The first and most common type is the distal and lateral onychomycosis. This presents as streaks or a patch of discoloration, white or yellow, at the free edge of the nail plate or near the lateral end, with secondary involvement of the underside of the nail plate of the finger or toenails. Then you have the proximal subungual onychomycosis, which involves the nail plate mainly from the proximal nail fold. This may be an indication of HIV infection. White superficial onychomycosis refers to an invasion of the nail plate on the surface of the nail. And here is a picture of the distal and lateral onychomycosis. This is tinea unguum affecting the toenail. Yet another variant of tinea is tinea incognito. The other name for this is steroid modified tinea. Now the clinical features of this condition are different from the usual tinea corporis that we see, in that the raised margin is diminished, inflammation is reduced, and the scaling is lost. The treatment is oral antifungals with a weak topical steroid. So now we move on to a more detailed description of the treatment of dermatophyte infections. Local therapy includes use of wet compresses about 3 times a day when the disease is very acute and inflammatory. You can use topical antifungals. They're usually clotrimazole, miconazole, terbinafine, cyclopyrox, olamin, or tolnaftate. Apply any one of these medications mentioned 2 times a day for about 4 weeks. Usually you see symptomatic improvement in about 2 weeks, but the extended use of this prevents a relapse. For thick lesions, use a formulation containing salicylic acid, example Whitfield's ointment. Now the systemic treatment includes allylamines, which includes terbinafine. The dosage schedule for tinea copperas is 250 milligrams once daily for 2 weeks. When you're treating tinea capitis, which is usually a disease of children, if the child weighs more than 40 kilograms, you can give 250 milligrams once daily for 4 weeks. For children between 20 to 40 kilograms, you give 125 milligrams once daily. And for children less than 20 kgs, you give 62.5 milligrams once daily. The schedule is for 4 weeks. When you're treating a dermatophyte infection of the fingernails, the treatment is to give 250 milligrams once a day for 6 weeks. When you're treating toenails, you need to give the treatment for 12 weeks. The common side effects that patients complain of are GI disturbances, skin eruptions including Stevens-Johnson syndrome, and they can also have hepatobiliary dysfunction. Therefore, the liver function should be monitored in patients treated for longer than 6 weeks. The drug interactions include rifampicin, cimetidine, terfenadine, and cyclosporine. The dosage of the drug should be adjusted when you're giving it along with the drugs mentioned. The other drug that we frequently use for the treatment of tinea infection is itraconazole. The dosage of this for tinea corporis and tinea cruris is 200 milligrams once a day for 7 days. If you're treating tinea of the feet or the hands, you need to give 200 milligrams twice a day for 7 days. If you're treating fingernails, then the way to give it is to give it in the form of what we call a pulse therapy. You give it as 200 milligrams twice a day for 7 days a month, 2 pulses of this for fingernail infection and 3 pulses of this for toenail infection. Again, the common side effects are related to the gastrointestinal tract. Elevation of liver function, liver enzymes occurs in about 5 to 10% of patients. Therefore, the LFT should be monitored if the treatment extends beyond 6 weeks. Important drug interactions include warfarin, cyclosporin, digoxin, and statins. Yet another drug which is given is crisufulvin. Its use is now limited mainly to the treatment of tinea capitis, and the dose is 10 milligrams per kilogram for 6 weeks in children. Arbitrarily, for children between 14 kilograms to 23 kilograms, you can give between 125 to 250 milligrams per day, and for children more than 23 kilograms, you can give between 250 to 500 milligrams per day. The drug should be taken with food as bile increases its absorption. Moving on to candidosis, which refers to infection by the yeast Candida albicans or by other species of Candida. Crisufulvin is yet another drug we use. Now, the use of this is being limited to its use in tinea capitis, the dose of which is 10 milligrams per kilogram for 6 weeks. Arbitrarily, For children between 14 to 23 kilograms, we give 125 to 250 milligrams per day. For children more than 23 kilograms, we give 250 to 500 milligrams per day. The drug should be taken with food as bile increases its absorption. Moving on to yet another superficial fungal infection, I'll be talking to you now on candidiasis or candidosis. Candidosis is an infection caused by the yeast Candida albicans or by other species of Candida. Candida albicans acts as a pathogen in the presence of impaired immune response or where local conditions favor growth, as when there's warmth or moisture. The predisposing systemic factors for this condition are broad-spectrum antibiotics, debilitation, diabetes, AIDS, immunosuppression or leukopenia. The clinical syndromes caused by Candida are oral candidiasis, which we are all very familiar with, vulvovaginitis, balanoposthitis, perianal and scrotal dermatitis, a diaper dermatitis, chronic paronychia, and congenital cutaneous candidiasis. Now, the clinical features of this condition varies with the site affected, but in general, on the skin, the common manifestations are erythema, maceration, and the presence of satellite lesions scattered along the edges of the larger macules. Paronychia is associated with rounding and lifting of the proximal nail fold, disruption of the cuticle, and erythema and swelling. The nail plate may display transverse ridging or greenish-brown discoloration. Intertriginous dermatitis, which refers to dermatitis of the flexures caused by Candida, presents as red, macerated, fissured plaques or patches. They are usually well demarcated, with peeling borders, and satellite lesions may be seen. Thrush, of course, as you know, presents as whitish plaques on the tongue. The underlying mucosa is a bright red. So here is a classical appearance of candidosis of the tongue. And here is an intertriginous dermatitis. And here you can see the chronic paronychia caused by Candida. There's loss of the cuticle, and you can see the swelling around the proximal nail fold, and one of the nails also shows a secondary dystrophy. And this is candidal intertrigo of the feet. Now, the treatment of candidosis. A. You must educate the patient about the role of moisture and maceration. The areas should be kept as dry as possible. For very inflamed skin, of course, you need to advise compresses. Topical antifungals, you can use imidazoles or you can use nystatin. And you advise the patient to apply the cream or ointment till the symptoms subside. The successful therapy of paronychia may take months. If you need to give systemic treatment, you can give fluconazole 50 milligrams once daily or itraconazole 200 milligrams once daily for about a week. Moving on to tinea versicolor, this is caused by malassezia. The factors predisposing to clinical infection include pregnancy, serious underlying diseases, oral steroids, and a warm, humid climate. Tinea versicolor persists because of inadequate treatment, reinfection, or an inherent predisposition to infection. And this is the reason why patients keep coming back to you with this infection. Now, tinea versicolor has a unique propensity to present as hyperpigmented or hypopigmented patches. The eruption is usually asymptomatic and occurs on the neck or the upper trunk. Facial lesions are more common in children. Now this is the classical appearance of tinea versicolor as hypopigmented, mildly scaly patches. And this is the classical meatball and spaghetti appearance of Pittosporum ovale or Malassezia. The treatment of tinea versicolor, one advises topical treatment which should be applied to the entire torso from the neck to the waist. Now you need to tell the patients that the pigmentary changes will resolve very slowly. For frequent relapses, the treatment should be continued for 2 consecutive nights a month for a year. These are the general principles when you manage tinea versicolor. The agents that we can use to treat tinea versicolor includes ketoconazole shampoo, which is applied to the skin, allowed to dry and left overnight, either as a single dose or daily for 3 consecutive nights. Antifungal creams, all the imidazoles, allylamines or tolnaftate can be applied twice daily for 2 weeks. You can also advise the patient to use selenium sulfide, which is applied and left in place for about 5 to 10 minutes before rinsing off, and this is used for 7 to 14 days. For systemic treatment, one can use fluconazole at a dose of 400 milligrams as a single oral dose, and it's best to repeat it a week later. You can also use itraconazole 200 milligrams daily for 5 to 7 days. Now for this lecture, my sources have been Andrews' textbook Diseases of Skin, the 10th edition, Rook's Textbook of Dermatology, 7th edition, and the Manual of Dermatology Therapeutics by Kenneth Arndt and Jeffrey Sue, 7th edition.